Welcome to Essentials of Acute Care. I am Dr. Sunil Garg. In my previous video, I discussed about antibiotic selection when infection turned out to be due to ESBL producing organism. In this video, I am going to discuss with regards to antibiotic selection when organisms are AmpC beta-lactamase producer. Remember not to be confused. If an organism is AmpC producer, still the same organism can also produce ESBL. So the challenge is that how to identify this situation. Also, the organism which commonly produce AmpC beta-lactamase can produce ESBL without any production of AmpC. AmpC beta-lactamase is produced by number of enterobacterial organisms, and it is also produced by glucose non-fermenting gram-negative bacilli. Here, by saying glucose non-fermenting gram-negative bacilli, I am referring to Pseudomonas, Acinetobacter and Stenotrophomonas maltophilia. Since AmpC is beta-lactamase, it hydrolyzes a number of beta-lactam antibiotics. Hydrolysis of antibiotics is possible depending on agent to agent, both in the setting of basal production of AmpC as well as in the setting of increased production of the AmpC. Whenever bacteria is exposed to the antibiotics, these organisms start producing increased production of AmpC. The production of AmpC beta-lactamase is mainly done by Enterobacter cloacae complex, Klebsiella aerogens and Citrobacter frundi. These organisms are at moderate to high risk for clinically significant AmpC production whenever they are exposed to antibiotics, and several beta-lactam antibiotics are relatively high risk of inducing AmpC genes. So, what should we do in this condition whenever there is organism and you try to give beta-lactam antibiotics? Does it mean the antibiotic will not be effective? No, this equation is not very straightforward. Even if the antibiotic is inducing significant AmpC production, the susceptibility of that antibiotic to these infections based on the ability of that particular antibiotic to withstand hydrolysis. So, both the ability to induce AmpC gene and inability to withstand hydrolysis should inform antibiotic decision making in such patients. With regards to infection with these organisms, cefepime has the advantage of both being a weak inducer of the AmpC and of withstanding the hydrolysis by AmpC beta-lactamase. So, cefepime can be considered if the infection is because of the AmpC beta-lactamase producing organism. With regards to non-beta-lactam antibiotic like trimethoprim sulfamethoxazole, fluoroquinolones, aminoglycosides, tetracycline and other non-beta-lactam antibiotics, neither they are substrate for AmpC hydrolysis nor they induce AmpC production. So these antibiotics are also effective whenever there is infection because of these organisms. With regards to treatment of such infections, cefepime is suggested for the treatment of such infection caused by the organism at moderate to high risk of significant AmpC production like Enterobacter cloacae complex, Klebsiella aerogens and Citrobacter frundi. But with regards to carbapenem is preferred only in those patients where the MIC of the organism is more than 4 microgram per ml, assuming carbapenem susceptibility is demonstrated, because in such patient it is assumed that there may be co-production of ESBL, and as we know that cefepime is not effective against ESBL producing organism. So in such patient carbapenem should be preferred over cefepime. In the treatment of invasive infections caused by these organisms which are at moderate to high risk of clinically significant AmpC production, third generation cephalosporins and piperacillin tazobactam are not suggested by the Infectious Disease Society of American guidelines. With regards to newer beta-lactam and inhibitor combinations, ceftazidime avibactam, meropenem avorbactam, imipenem/cilastatin, relibactam and cefiderocol is preferentially reserved for treating infection caused by the organism which shows carbapenem resistance. So, nitrofurantoin and trimethoprim sulfamethoxazole are preferred treatment option for uncomplicated AmpC enterobacterial cystitis, as these are the preferred therapy also for ESBL uncomplicated cystitis. Aminoglycosides are alternative treatment option for uncomplicated cystitis, pyelonephritis and complicated UTI caused by these organisms. So all in all, the preferred therapy for such infections are cefepime, but if cefepime MIC is more than 4, then carbapenem are the preferred therapy. The alternative therapy for the invasive infection include trimethoprim, sulfamethoxazole combination or fluoroquinolones can be considered for the treatment of such infections. So we need to remember that these enterobacterials which are known to produce AmpC beta-lactamase can produce ESBL also, or they can produce ESBL alone. While the preferred therapy for any beta-lactamase producing organism, whether it is AmpC or extended spectrum, it is either carbapenem or non-beta-lactam, as if cefepime is effective against only AmpC and not against ESBL. Here I finish. I will appreciate your feedback, suggestion and comments, and thanks for watching this video.